Hello and welcome to a post-recording of December 2022's ICU Journal Club. Today we'll be discussing the ABC trial. So why such an old article? Well, this is the first building block to improving our ICU liberation bundle. This is the article that kicks it off. But since the article is so old, I've added a very brief mini lecture at the end of this presentation to ensure that you leave knowing the standard of care in regards to ICU liberation. Before moving forward, let's make sure everybody's on the same page and go over some common jargon that's applicable to ICU liberation. First, a SAT is a spontaneous awakening trial, and SBT is a spontaneous breathing trial. So I've built in plenty of redundancy in this presentation to go over an awakening and breathing trial. So by the time you leave this webinar, you will be confident in doing so and how to perform one. You'll also see PADIS if you're doing any increased research or any reading after this, and this stands for pain, agitation, sedation, delirium, immobility, and sleep disruption. Quite the mouthful. And this is the Society of Critical Care Medicine's guideline in regards to pain and agitation management. And then lastly, you'll see a very common phrase, ICU liberation. And this is really brought on by the ABCDEF bundle. A is the assess and prevent manage pain arm. B is both SAT and SBT. C is the choice of analgesia and sedation. D is delirium assessment, prevention, and management. E is early mobility. F is family. And soon enough, in the next decade, we probably will have a G for good sleep. They're just accumulating relevant data at this time. So now a little background. And when I set the background, I want to set the background like the article just came out today. So this is prior to 2008. This is what the primary investigators were exploring. So first of all, they knew that oversedation and prolonged ventilator use really came with increased morbidity. Oversedation led to prolonged ventilatory time, and we knew that vent weaning protocols reduce ventilatory time. And there was a signal in the literature that awakening trials could improve vent weaning, but solid data was really lacking. And on top of that, there was a huge concern for patient safety. So what's the paper we're exploring today? It's the ABC trial, Awakening and Breathing Control Trial, Efficiency and Safety of a Paired Sedation and Ventilatory Weaning Protocol for Mechanically Ventilated Patients in Intensive Care. And what was the clinical question? Do spontaneous awakening trials improve patient outcome when combined with routine spontaneous breathing trials in mechanically intubated sedated patients? To expand on the clinical question, let's take a look at our PICO format. So P for patient or population, we had non-surgical patients. We'll talk about that more briefly. They were adult patients that was defined by being 18 years or older, and they needed to require ventilatory support for 12 hours or greater. I for the intervention was usual care. We'll go over what that is. But the intervention received usual care plus a daily spontaneous awakening trial. C for the control was usual care. Again, we will discuss what that is. And then O for outcome. What were they looking for? They were looking at the number of days patients were breathing without ventilatory support during a 28-day study period. So let's expand on what usual care is and what the intervention was. So in usual care, of all patients, they received targeted sedation. The definition of targeted sedation in the paper was titrating sedative and analgesic doses to maintain the level of arousal and comfort deemed clinically appropriate for each patient. And this wasn't set in a structured format. This wasn't protocolized. This was deemed appropriate by the attending physician caring for the patient. All patients received analgesic support, and then every morning they underwent a spontaneous breathing trial safety screen. If they passed that safety screen, they went on to a spontaneous breathing trial. We'll discuss in more detail what exactly these could include. And if the patient passed the spontaneous breathing trial, the respiratory therapist and/or registered nurse approached the doctor for a yes or no to extubate. It should be pointed out that attending physicians that were involved in this paper were urged to extubate as soon as possible once their patient did pass a spontaneous breathing trial. Now let's take a look at the intervention arm. So they received usual care, but before they moved forward with a spontaneous breathing trial safety screen, they underwent a spontaneous awakening trial safety screen. If they passed that screen, you got it, they moved forward with a spontaneous awakening trial. If they passed the SAT, Then they went on to a spontaneous breathing trial. And the spontaneous breathing trial was the same in the intervention arm as it was in the control arm. And then lastly, if they tolerated the breathing trial, the doc got the final say of yes or no, the patient was going to be extubated. So let's reiterate how this process occurred. You were enrolled and randomized, and you were put into one group or another. So let's first take a look at the control group. The control group, as we discussed, received a spontaneous breathing trial. In the morning, every day, daily, the patient received a spontaneous breathing trial safety screen. If they got check boxes in all of these items, they were able to move on. So they needed to not be hypoxic on minimal support. They needed to have spontaneous respiratory effort and no agitation. No myocardial ischemia in 24 hours. So this could be EKG changes, chest pains, or elevated troponins. No significant use of vasoactives. The study defined this as dopamine or dobutamine less than 5 mics per kilo per minute. If you were on norepinephrine, it had to be less than or equal to 2 mics per minute. And you could be on any dose of vasopressin or milorone. If you passed the safety screen, you went on to a spontaneous breathing trial. If you failed the safety screen, you were stopped and reevaluated in a 24-hour period. Now let's say you've moved forward to the spontaneous breathing trial. There was safety check marks, safety stops here. If you met any of these, you failed and you stopped your spontaneous breathing trial. So if you were tachypnic or if you had a low respiratory rate for greater than 5 minutes, that was a red flag. If you were hypoxic, if you had an abrupt change in mental status, or if you had any acute cardiac arrhythmias. And then any 2 signs of respiratory distress, it could be tachycardia, bradycardia, use of accessory muscles, abdominal paradoxis, diaphoresis, or dyspnea, you failed, you were stopped, and you got reevaluated in 24 hours. But let's say that you passed your SBT. Now the ICU doctor was prompted, stating that your patient has passed spontaneous breathing trial. Are you ready to extubate, yes or no? Now let's take a look if you were put in the intervention arm. And again, as a reminder, the intervention arm is not only a spontaneous breathing trial, but before that, a spontaneous awakening trial as well. So every day, daily, you received a spontaneous awakening trial safety screen. If you hit all these check marks, you were able to move on. You passed. So you were not on any neuromuscular blocking agents, no active seizures or any continuous infusions that were treating the seizures, no alcohol withdrawal and or any infusions that were infusing to treat the alcohol withdrawal, no escalating sedatives or increased agitation. So if this was the patient that was kicking you in the chest and you doubled his sedation an hour prior, this patient did not meet criteria to move forward. No myocardial ischemia within the last 24 hours, and no evidence of increased intracranial pressure. If you pass the spontaneous awakening trial safety screen, you went on to the spontaneous awakening trial. If you failed it, you were stopped and reevaluated in a 24-hour period. Now, once you've moved on to the SAT, there was also safety stops at this point as well. But if you passed your spontaneous awakening trial, you moved on to the breathing trial safety screen, as I depicted in the previous slide. If you passed your breathing trial safety screen, you went to your breathing trial. And if you passed that, once again, the ICU doctor was prompted and they made a decision whether you extubated or not. Now let's say that you did not pass your spontaneous awakening trial, and what were those red flags that stopped the awakening trial? So pretty much everything in the spontaneous breathing trial safety stop checklist, but also including sustained anxiety, agitation, or pain. So if that patient failed the awakening trial, they were restarted on 50% the dose of the sedative that they were previously on, and then they were reevaluated in a 24-hour period. Some important tidbits here. A spontaneous awakening trial could occur for up to 4 hours. And to pass that awakening trial, all you had to do was open your eyes to verbal stimuli or last the 4 hours without exhibiting any evidence of failure. Now, when it came to the breathing trials, those lasted 120 minutes regardless, and you had to reach that 120 minutes to pass. Now let's take a look at the design and methods of the trial. So this was a US-based trial. It was multi-centered, randomized, controlled. It enrolled patients from 4 major large US centers, 1 in Nashville, 2 in Philadelphia, and 1 in Chicago. It enrolled patients from October 2003 to March 2004, and then there was a 1-to-1 computer randomization by Vanderbilt. Now, Vanderbilt was not the hospital that enrolled patients in Nashville. Vanderbilt actually acted as almost a research center. They would answer any questions about study design and address any concerns for adverse effect. After the randomization, a sealed envelope was handed to the treatment team, and that's how there was recognition of what arm of the study the patient was enrolled into. As stated before, all patients received analgesia and all patients received patient-targeted sedation that was deemed clinically appropriate by their attending MD. The morning after the enrollment, the study protocol began. So if you enrolled me today, tomorrow morning is when my study would actually start. Another thing I want to point out that's not on this slide is that the enrollment screened all patients for eligibility. So not just newly admitted patients. On day one of the study, they screened all their patients in their ICUs. And then most importantly to me in this slide is that this was a ICU RN, respiratory therapist driven protocol. There was very little to do with a doctor or an advanced practice provider for that matter. It was an ICU RN and RT driven protocol. Patients were followed until death or discharge, and then survivors were followed for 1 year. The investigators used EMR, phone calls, in-person visits, and yes, the Social Security Death Master File. That is actually something is real, and anybody can really access it. There was 2 a priority interim analysis for adverse effects, and this was planned and conducted at 30 and 100 patient enrollment. So to clarify, there was an interim analysis for adverse effect, but there was not an interim analysis for efficiency. Looking at inclusion criteria, you had to be an adult. This was defined by 18 years or older. You needed to require mechanical ventilation for 12 or greater hours, and you had to be a non-surgical patient. And they designed this on purpose. And it was because there was a presumption that these folks might have been in acute pain and would require continuing analgesic infusions, and that might compromise the ability of the study design to be able to be replicated in the future. Looking at the baseline characteristics, they're pretty equal between the folks in the intervention group and the control group. There is one blatantly blaring thing that we all should capture here, and it's the RASS on the first day of the study. There was a mean RASS of -4. That should really set you back a bit. A RASS of -4 is essentially considered a coma. And unfortunately, more than half of the patients in each group were comatose on day 1 of the study due to sedation. Just to give you a refresher, the RASS, Richmond Agitation Sedation Score, what's in red down there, the -4 and -5, deep sedation or unarousable. These are the folks that are diagnosed with coma when it comes to this trial. And just to reinforce, a patient on a ventilator, we would prefer their sedation to be 0 to -2, so alert, calm, or drowsy, or at the deepest, light sedation where they would briefly awaken to voice. Now let's take a look at the exclusion criteria. So admission after cardiac arrest, folks were excluded. If people were on mechanical ventilation for 2 weeks or greater, they were excluded. I want to point out once again, all patients were screened on day 1 of the trial. So when that trial started, they went to all their ICUs and started screening their patients. So if there was a patient in there that was on the ventilator for 2 weeks or greater, they were excluded. Other exclusion, death was perceived to be imminent. There was withdrawal of life support, profound neurological deficits, or they were enrolled in another study. They screened 1,658 patients. They excluded 1,322 patients. And the one thing I want to point out in this box, 324 patients had their surrogate or physician refuse. That's to say a proportion of these folks that were excluded was due to physician refusal. At the end of the day, they were able to obtain 336 patients that were randomized to 168 to each allocation arm. Now let's take a closer look at the control arm. So redundancy is intended here. The patient received targeted sedation, and the sedation level was determined by a treating doctor. There wasn't a protocol for this. All patients received analgesic support, and every morning they underwent a spontaneous breathing trial safety screen. The SBT lasted 120 minutes. If the patient failed, the SBT was stopped and they were reevaluated in a 24-hour period. If the patient passed the safety screen, they were moved on to the spontaneous breathing trial itself. The SBT could be conducted in one of 3 ways. The first would be pressure support ventilation with a PEEP of 5 and a pressure support 7 or less. The physiology, the thought process behind this, the patient is given +5 of PEEP. This maintains our physiological PEEP of you and I with a normal BMI walking around between 3 and 5. This ensures alveolar recruitment. And then the pressure support is added flow, added support to breathe through the resistance of the ET tube. Another way a SBT could have been conducted was CPAP. So this was an intubated patient with no pressure support, only PEEP. So they did not receive added pressure support to overcome the resistance of the circuit in the ET tube. They just received their 5 of PEEP to help maintain physiological recruitment of their alveolus. And lastly, a T-piece could be used. So a T-piece, the patient is still left intubated, the ventilator circuit is removed, a T-piece adapter is placed on the ET tube. One side of the T-piece has humidified oxygen blowing by. The other side of the T-piece is essentially exhaust for the patient to exhale against. The patient has no PEEP, no positive end expiratory pressure, and they have no added pressure support to overcome the resistance. If the patient passed the SBT, which lasted 120 minutes, the attending MD was asked if they wanted their patient extubated, yes or no. And again, the study design, the primary investigators urged all the attending physicians to extubate as soon as possible. Now let's take a look at the intervention arm. So the intervention arm received all the usual care that we just spoke about, but before they went on to their breathing trial screen, they got a daily spontaneous awakening trial safety screen. If they passed that, they went on to their awakening trial. If they passed the awakening trial, they went on to the spontaneous breathing trial screen. So how exactly was a SAT initiated? So all sedative and analgesics used for sedation were stopped abruptly. I feel this is important to underline here. They weren't weaned, they weren't cut in half, they were abruptly stopped. The next question that normally follows this when I point this out in the paper, what if they're on an analgesic infusion, like a fentanyl infusion? What do we do? Well, the analgesic is only continued if the patient has active pain. And the normal comment after that is, well, that's a lot of our patients. But it's not. It's active pain, not being treated for pain, active pain. And in the trial itself, only 15% of awakening trials had the analgesic infusion actually continued. So it's an outlier, not a constant. The patient received a spontaneous awakening trial, and they either passed or they failed. If they failed, the awakening trial was stopped. They were restarted on 50% of their previous dose of sedatives, and this could be titrated back to a targeted goal, and they were reevaluated in 24 hours. If the patient passed, once again, the only thing the patient had to do was open their eyes to verbal stimuli and or tolerate 4 hours of an awakening trial without exhibiting failure. They then moved on to a spontaneous breathing trial safety screen. How about the primary outcome of the trial? It was a number of days patients were breathing without assistance from the ventilator during the 28-day study period. So essentially, this was ventilator-free days during this 28-day period. I want to point out that the definition of a successful extubation in this trial was defined by at least 48 hours off the ventilator of unassisted breathing. If a patient died during the study period, they were assigned 0 ventilator-free days. Looking at secondary outcomes, they included time to discharge from the ICU, time to discharge from the hospital, all-cause 28-day mortality, 1-year survival, and duration of coma and delirium. Important to take a look at how they define coma and delirium. They defined coma by a RASS of -4 or -5, and they diagnosed delirium by using the CAM-ICU method. This is confusion assessment method for the ICU. Now let's get into some of the nitty-gritty and take a look at the stats. So based on some pilot databases, they expected a mean of almost 13 vent-free days in the control group. That was the group that just got the breathing trial. Their power analysis was for 334 patients in order to detect a 25% increase in ventilator-free days. So if you do the math, they were looking for about 16 vent-free days in the intervention group that got both the awakening trials and the breathing trial. It was done for 80% power, which is acceptable, and the two-sided significant level of 0.05, which is common for medical research. And important to point out, this was an intention to treat analysis. They used chi-square testing to compare the variables. This is pretty common. However, they did use WMW, two-sample rank sum, and bootstrapping. So these latter two testing methods are very complex statistical resampling techniques, and it makes the normal everyday bear like me have a very difficult time in interpreting and critiquing the data. We'll talk more about that soon. Looking at the results, first I just want to show protocol adherence. Impressive to point out, folks in the intervention group, 90% underwent awakening trials. Also important to point out, in the control group, 0 patients underwent a spontaneous awakening trial. And you might be saying, well, yeah, that's the control. But the doctors in the control group had the option of giving their patient an awakening trial, and none of them did it. In the intervention group, 90% of the patients' sedatives were held before a breathing trial, where only 31% in the control group. Benzodiazepine use was higher in the control group statistically, and there was a non-statistical trend to more opiate use in the control group as well. When we look at the primary outcome for ventilator-free days, there was a difference between the intervention group and the control group. There were more ventilator-free days in the intervention group, 14.7 days versus 11.6. This made for a mean difference of 3.1 days. They assigned 95% confidence interval, and the confidence interval was 0.7 to 5.6 with a p-value of 0.02. Some things to point out here. This is a very wide distribution, and in addition, the confidence interval crosses 1. So the wider the confidence interval, the more uncertainty there is for the results. In addition, usually when the confidence interval crosses 1, there's no difference between the arms. I would surmise this is why they use some resampling techniques to do their data. The secondary outcomes, which again are just hypothesis generating, but should support the primary outcome, show a decrease in ICU length of stay, a decrease in hospital admission time, and surprisingly a decrease in 1-year mortality. So if you look at this up close, it has a hazard ratio of 0.68. So essentially, folks that were in the intervention group were 32% less likely to die, and that would leave you with a number needed to treat of 7-to-1, meaning I would only have to do the intervention of a waking trial to save 1 life. There was less coma in the intervention group, as well as a lower RAS level overall. Now, let's just slow down for 1 second here. Let's take a look at any self-extubation. So the intervention group was much higher than the control group. So 16 for 6 patients, so 10% versus 4%. This was statistically significant. But now take a look at self-extubations requiring intubation, and there was no change. So the historic teaching of this data was we're really not doing our job well enough to extubate our patients because the ones that did self-extubate flew. Now let's take a look at limitations. Well, this trial was not blinded, but honestly, it wasn't possible. It just is what it is. There was no mandated sedation protocol, and this is a big gripe in my eyes. There was no mandated RAS. It was at MD discretion, variable among different patients. There were no surgical patients. We pointed out why. There was a worry for potential for need for continuous analgesia. And then the eligibility of the 324 patients that were excluded, a proportion of that group were MD refusal. And then lastly, there was very complicated statistical tools to reach a conclusion, and looking and crunching down in the stats. If this paper wasn't from 2008 and some of the components weren't already replicated by now in 2022, there would be some debate, in my opinion, to question the results. So what was their author's conclusion? So quote unquote, our results show that a paired sedation and ventilator weaning protocol consisting of daily spontaneous awakening trials plus spontaneous breathing trials resulted in patients spending more time off mechanical ventilation, less time in coma, and less time in the ICU in the hospital, and the protocol improved 1-year survival compared with usual care. So what were my takeaways from this? First, before I even start, I'll underscore 3 more times if I have to. This is an RN and respiratory therapist-driven protocol. The MD or APP only needed to step in for an extubation, yes or no. I feel this paper helped me understand that a combination in a waking trial and breathing trial leads to a more alert patient. This potentially means the patient's more interactive. They can be more compliant with mobility. It leads to more ventilator-free days. It leads to less coma and oversedation. And I do need to remember that it may lead to more self-extubation, but really that just means I have to do a better job in assessing my patient's readiness for extubation and weaning. And if they extubate sooner, it makes sense that they would move out of the ICU quicker. And this is a good example of a secondary outcome, ICU length of stay, supporting primary outcome, which would have been an improvement in ventilator-free days. So I had some thinking here, some pondering. If this study was done today, they would tell you to do a no benzodiazepine approach. And when a benzodiazepine was used, there would be a need why it was done. It would be a mandated RAS protocol between 0 to -2, which is the standard of care. We would have an avoidance of opiate infusion, and we would do a bolus dose first methodology. And only if there was failure at the bolus dosing regimen would we consider opiate infusions. We would mandate sedative protocols, and mainly the drugs revolving around that would be dexmedetomidine and propofol. And then we would encourage a structured mobility format. And lastly, I have to question, would the results have been the same if the standard of care today, a RAS of 0 to -2, were adhered to? So this is where Journal Club ends. I have a few slides here that are really mini lecture format. And the reason why I wanted you to walk out of this webinar knowing what the standard of care was right now, so tomorrow you can optimize your care. So what are the current day recommendations? And it really revolves around the ICU Liberation Bundle. And this includes using triggered analgesia. We want to use a validated pain scoring method. If the patient is awake and talking, we can use the numerical rating scale. If they're not talking, we can use the critical care pain observation tool. We want to use multimodal pain management, and this really includes both opioids and non-opiates. What are examples of non-opiates? Acetaminophen, gabapentinoids, and low-dose ketamine. And we also want to practice non-pharmacological pain management as well. We want to do daily spontaneous awakening trials per a protocol screening algorithm. Do we need to do a protocol? And the answer is yes. Multiple lines of evidence have demonstrated that clinicians often underappreciate the ability of patients to undergo safe discontinuation of sedation. So yes, we need a protocol to push us. Another point that I want to make is that it's very important that we abruptly stop the sedative. Pharmacokinetics of drugs are really altered when we're critically ill, and this delays clearance of sedatives. So this thought process of gradually lowering it until we get the patient where we want is not recommended. And then again, analgesic infusion should be held in most cases. Next, we're going to do spontaneous breathing trials, and these are going to last anywhere from 30 to 120 minutes. Patients ventilated for greater than 24 hours. The initial spontaneous breathing trial should be performed with a pressure support ranging from 5 to 8 rather than a T-piece, and most institutions use 5 a PEEP with that. And that's at the recommendations of the American Thoracic Society and American College of Chest Physicians clinical practice guidelines. Next, we need to choose our analgesia and sedation appropriately. If we're going to use opiates, we want to do a bolus therapy approach first, and we really want to decrease the use of our continuous infusions. We reserve those continuous infusions for failure of bolus therapy. We want to do a benzodiazepine approach. Benzodiazepines are linked strongly with delirium, and we want to respect a RASS sedation level of 0 to -2. We need to do delirium assessment. That's either by an intensive care delirium screening checklist or the CAM ICU method, and we want to practice delirium prevention and management. Let me step back just a bit for that. What is delirium prevention? This is honoring a day-night sleep cycle. This is reorientation. This is providing the patient with their glasses and their hearing aids, so on and so forth. And what is management? Well, once we diagnose delirium with our CAM ICU or ICDSC, we need to stop. We need to put a stop sign up on rounds and say stop. The person is delirious. Why? What medications are deliriogenic we can remove? What are some other tactics that we can utilize to prevent or reduce delirium in itself? We want to practice early mobilization and exercise. We want to involve and engage and empower the family. And then lastly, in the next few years here, there will be a lot of talk about good sleep. It's important that our patients are sleeping. I'll leave you with one thought on that. Just because we deeply sedate a patient with a sedative does not mean they're sleeping. They are not receiving good REM sleep. Everything I just covered here in the last few slides are really an example of the ICU liberation protocol, A through F. Normally, if we were in person right now, we would have a group discussion. However, I hope you enjoyed the Journal Club. If you need any resources, if you want to do any more research with the ICU Liberation Bundle, I would suggest these 2 websites. This book here, ICU Liberation 2nd Edition, is provided by Society of Critical Care Medicine, another great resource. As always, if you have any questions, please reach out to me at rgibson2@chsbuffalo.org. I appreciate your time and your attendance. Get out there and get some patients off the vent and prevent delirium.